highlighted here. And I would like to give you my thoughts about how things are managed in Ghana as an example. And I want to thank Bafour for allowing me to spend a little bit of time in his hospital and see how they are organized. And I will give you information based on that. It's not generalizable probably, but it's a hands-on experience that I think it's important to be discussed. So Kumasi is the second largest city in Ghana, which has about 20 million people living in the country, and it's the Comfort Anoche Teaching Hospital, the CAS, the hospital that I visited in Ghana. First thing, drugs, are they available or not? Well, they are available. There are a number of drugs that are available, and these are pictures that I took in the pharmacy. You can see here tamoxifen, you can see here Arimidex, you can see here doxorubicin. These are the drugs that are available, and some of them are reimbursed by their starting national health scheme. The facility to administer systemic therapies. This is a picture showing how their day hospital looks like, and I was impressed. I was impressed what I've seen there, the way they were organized. You can notice here the oxygen and other things that were needed. I had the pleasure of discussing with one of the nurses there, and I was impressed by how they managed to compound the drugs. This is usually a problem. You need to be careful how you handle the cytotoxics. Well, what they had was they used an incubator for doing that, and it was quite nice because it provided a protection for the person that was doing the compounding, and it was done, I think, in a manner that could be safe both for the nurse and also for the patient. Record keeping was also very well managed, I believe, because they had the files of all the patients. You could retrieve the files of the patient quite easily to see what was going on, and also based on the record that they were keeping for the chemotherapy administration in the day hospital. And although they didn't have, the labels, the printed labels that we use, they had this system of having labels to put on the chemotherapy bags that were given to the patient, which worked quite well in practice. However, there were a few observations that I've made, and that in fact are that drug choice is driven by availability, and in many cases patients were treated, or the decision of treating one patient was based more on what was available on site than what should have been proposed by the NCCN guidelines, for instance. Bafour is doing an excellent job, and the people that he's working with are doing an excellent job. But what they are doing is, in fact, they are providing multi-specialty care by a single specialty. They're radiation therapy specialists. However, they're trained to be able to offer chemotherapy and systemic treatment to their patients. The infrastructure needs are not always supported at the governmental level, and the institutional collaboration is hampered by the fact that there are different distance between the institutions and other issues. Thinking about delivering chemotherapy, I would submit to you that chemotherapy is not the regular drug that we all in medical school learned how to use. I would say that it's not as easy to administer as antibiotics or any other drugs. You have to know a little bit of how it works, about the dose effect. You need to know a little bit about the mechanism of action so that you hit the right target or patient, if you will. You have to be really aware about the toxicity that chemotherapy can bring to your patients, and how to manage that toxicity, and it's not trivial always. And you also have to be able to evaluate what you're doing. I've seen most of the patients treating at Cath. There were a number of patients treating in the adjuvant setting, but most of them were treated in the metastatic or locally advanced setting. And response evaluation is really important. You need to know what you're doing with your treatment. And this is an example of a CAT scan. Obviously, that's not it's just for illustration purposes. But you need to have in mind this, that you need to evaluate your patient. Otherwise, you don't know how to do treatment. So. Thinking about the ways we use chemotherapy, we use adjuvant chemotherapy after complete removal of our tumors. We use neoadjuvant chemotherapy, and mostly in low and middle income countries, before local treatment, because most of the patients are locally advanced. And we also use palliative chemotherapy. And is it possible to deliver it without medical oncologists? I think it is, because in a number of countries around the world, the clinical oncologist is actually the one who's doing both radiation therapy, is doing also systemic therapy. But I do think that you need special training. I believe that motivated physicians, internal medicine, radiotherapists, surgeons can acquire the skills, but they need special training. Adjuvant treatment is easier than metastatic treatment in a way, because there's a recipe. You know, you've taken off the tumor, then you know you'll give a certain number of chemotherapy cycles, and that's it. But errors in the adjuvant system can have greater impact, and the errors are concerning the drugs that you use or the dose that you use. And I will just highlight one thing, that dose is very important for adjuvant chemotherapy for early stage breast cancer. And I picked up this slide which shows CMF chemotherapy, which is one chemotherapy that probably is used more in low and middle income countries, where if the optimal dose is not over 85%, you'll have a decrease in overall survival, which is quite important. So dose is very important, at least for breast cancer in the adjuvant treatment. So it's something that you should keep in mind. And again, when talking about metastatic disease, I believe that in order to be helpful to your patient, you need to be able to evaluate response. You need to be able to tell him whether the tumor is responding or not, and to make your judgment based on that, when to continue treatment, when to go to the next available drug. So that's not a trivial task. That's not what we are usually taught in medical school. There's also the issue of quality of life for treating metastatic breast cancer patients, which is also something that we are not always taught. We have to balance toxicity, efficacy. We have to take into consideration all kind of stuff when we make our decision when treating metastatic breast cancer patients. The curricula in Ghana for radiotherapy specialists specifically says that residents are required to have experience in the use of cytotoxic agents. A minimum of 3 months rotation in a medical oncology facility will be required. And that the candidate should possess knowledge of the mode of action of the various chemotherapeutic and hormonal drugs in the treatment of neoplastic disease, and a detailed knowledge of their therapeutic uses. I endorse this. I think it's very important, but I'm not sure that this is enough to be able to offer systemic treatment to your patient. Again, so what shall we do? Shall we start and write a book? I don't think that's easy. I don't think that that's easy, because we have so many things that we have to take into consideration when we make treatment selections. The tumor biology, the chances of response to therapy, the fear of symptoms of the patient's preference, which is a question I mean, it's not even discussed very much in low and middle income countries, toxicity, etc. So in conclusion, I think I've shown you that medical oncology is a sophisticated specialty. I think that in low-resource environments, systemic treatment is delivered. It's actually happening. It's delivered in the absence of medical oncologists. I think that enthusiastic and motivated teams can overcome system limitation. but the optimal management of systemic therapies requires, even in low-resource countries, specialized formal training. And I'm happy to learn this morning that Bob Carlson will be doing work in this area, so I wish you good luck with that. So I don't think it's easy.